Today's drug is the one every other opioid gets measured against. When we say fentanyl is 50 to 100 times more potent than something, that something is morphine. It's the reference point, the baseline, the drug that gave opioid receptors their name in the first place. Isolated from opium poppy sap back in 1806, poppy sap is a milky white latex found inside the unripe seed pods of the opium poppy, Papaver somniferum. When dried, it forms crude opium, which contains powerful psychoactive alkaloids like morphine and codeine. Morphine is named after Morpheus, the Greek god of dreams. Morphine has been in continuous clinical use longer than almost any drug we still reach for today. Let's dig into why it still matters. What kind of molecule is this? Morphine is a natural phenanthrene alkaloid pulled straight from the opium poppy plant. It's a weak base, and it's not particularly lipid-soluble compared to the synthetic opioids that came later. That poor lipid solubility is going to explain almost everything unusual about how morphine behaves, so keep it in mind as we go. It still handles both sharp somatic pain and deep visceral pain effectively, but as we'll see, it actually shines brighter on the slow, dull, continuous kind of pain, rather than sudden sharp pain. How it works at the receptor level. Morphine is the textbook mu receptor agonist, the drug every pharmacology course uses to define what mu receptor activation looks like. It does hit kappa and delta receptors too, but weakly. The mu receptor is doing almost all of the work. Here's the chain of events once morphine binds a mu receptor. The receptor is coupled to an inhibitory G protein. Binding shuts down adenylyl cyclase, which drops intracellular CAMP. At the same time, potassium channels open, letting potassium flow out, and calcium channels close, blocking calcium from coming in. Put those two ion movements together and the neuron hyperpolarizes. It becomes much harder to fire. A neuron that's hyperpolarized releases far less neurotransmitter, specifically less substance P and less glutamate, the two chemical messengers that carry pain signals up the spinal cord. Less transmitter release means less pain signal getting through. That's the entire story of opioid analgesia in a few steps. Inhibit the cell, inhibit the release, inhibit the pain signal. Beyond analgesia, this same mechanism across different brain regions produces sedation, euphoria, respiratory depression, and pupil constriction, all side effects of the identical receptor pathway acting in different places. Getting it into the patient. Give it IV, and you'll see effect within 1 to 5 minutes. Peak effect somewhere between 5 and 20 minutes, lasting roughly 3 to 4 hours. IM injection is slower. Onset takes 15 to 30 minutes, with peak effect landing 45 to 90 minutes in. And here's a fact that trips people up. Give morphine by mouth, and only about 25% of the dose actually makes it into circulation. The rest gets caught up in first-pass hepatic metabolism before it ever reaches the systemic circulation. That's why oral dosing needs to run so much higher than the IV dose to achieve the same effect. Where the drug goes once it's in. Morphine distributes into a volume of roughly 2 to 4 liters per kilogram, and only about 30 to 35% of it is bound to plasma protein. Now, here's where the poor lipid solubility we mentioned earlier really shows up. Morphine crosses into the brain slowly, much more slowly than fentanyl. 3 things conspire to keep it out. Low lipid solubility to begin with, the fact that it's significantly ionized at physiologic pH, and active efflux pumps at the blood-brain barrier that actively push it back out of the CNS. This is the entire reason morphine's onset feels noticeably slower than fentanyl's, even when given by the same IV route. What the liver does to it. The liver metabolizes morphine almost entirely through glucuronidation. This produces 2 distinct metabolites, and you need to know both of them. Morphine 3-glucuronide, or M3G, makes up the majority, somewhere around 75 to 85% of the dose. M3G has essentially zero analgesic activity, but it's been implicated in causing neuroexcitatory effects, things like myoclonus and agitation, particularly when it accumulates in large amounts. Morphine 6-glucuronide, or M6G, makes up a smaller share, roughly 5 to 10%, but don't let that small percentage fool you. M6G is a potent mu receptor agonist in its own right, providing real analgesia, real respiratory depression, and it actually outlasts the parent morphine molecule. This matters enormously in patients with reduced kidney function. Since both metabolites get cleared renally, a patient in renal failure will accumulate M6G, and that means prolonged, sometimes dangerously enhanced respiratory depression, well after you'd expect the morphine dose to have worn off. Elimination half-life for the parent drug sits around 2 to 4 hours, but remember, the metabolites can hang around longer and keep exerting effect. Where this drug actually gets used. Morphine remains a workhorse for moderate to severe acute pain, trauma, postoperative recovery, burns. It's also excellent for chronic cancer pain, where the sustained, continuous nature of morphine's analgesia fits the pain pattern well. Historically, it had a role in acute MI management, providing pain relief while also calming sympathetic overdrive. That use has become more selective over time, as other options have taken its place. Pulmonary edema was another classic indication. Morphine's venodilation drops preload, and its anxiolytic effect calms the air hunger that comes with acute decompensation. This use has also fallen out of favor somewhat, given concerns about hypotension. In the OR, it fits into balanced anesthesia and perioperative pain control. And neuraxially, it's outstanding for both labor analgesia and postoperative pain, which we'll come back to shortly. What's happening in the brain? Morphine delivers strong analgesia, sedation that most patients notice readily, and typically a sense of euphoria. But here's an important nuance. If you give morphine to someone who isn't actually in pain, you can get the opposite reaction, dysphoria instead of euphoria. The pupils constrict down to pinpoint size, and interestingly, that particular effect resists tolerance almost entirely. Patients on chronic morphine will still show pinpoint pupils years later. It also suppresses the brainstem's cough center, which is why morphine and related opioids have historically been used as antitussives. With repeated dosing, tolerance builds, and physical dependence develops alongside it. The limiting factor: breathing. Respiratory depression is what ultimately caps how much morphine you can give. The medulla's normal sensitivity to rising CO2 gets blunted, respiratory rate drops, tidal volume drops, and if it goes far enough, you end up with both hypercapnia and hypoxia. Layer onto that a reduced cough reflex and some bronchoconstriction from histamine release, and you can see why patients with COPD or obstructive sleep apnea need extra caution. The heart and vessels. Morphine doesn't do much direct damage to the heart muscle itself. What it does do is trigger histamine release, and that histamine causes vasodilation, which can drop blood pressure. Watch for orthostatic hypotension in patients who sit up quickly, and occasionally you'll see reflex tachycardia in response to that vasodilation. The reduction in overall sympathetic tone is actually useful in patients whose pain is tangled up with anxiety, calming both simultaneously. The rest of the body. In the gut, expect nausea, vomiting, slowed gastric emptying, and constipation. And unlike the pupils, tolerance to constipation barely develops, even with long-term use. Urinary retention shows up fairly often, and that histamine release we mentioned for the cardiovascular effects also drives itching and skin flushing. The high-yield takeaways. A few things worth locking in permanently. Morphine is the reference standard. Every other opioid's potency gets described relative to it. It handles ongoing, dull, visceral pain better than it handles sharp, brief pain. Oral bioavailability sits around just 25% because of heavy first-pass metabolism. Its CNS penetration is genuinely slow, Poor lipid solubility, significant ionization, and active efflux transport all work against it. M6G is a real, active analgesic metabolite that accumulates dangerously in kidney failure. And histamine release is one of the features that most clearly separates morphine from fentanyl. Fentanyl barely triggers any histamine release at all. Who needs extra caution? Be careful in patients with existing respiratory depression, severe asthma or COPD, elevated intracranial pressure, hypotension, renal failure because of M6G buildup, hepatic impairment, and anyone on concurrent CNS depressants. Pregnancy and breastfeeding call for a careful risk-benefit conversation. And MAOI therapy, while rare in practice today, raises the risk of serious toxicity if combined with morphine. How it stacks up against other opioids. This comparison shows up constantly, so let's run through it. Morphine sits at 1 times potency, the reference point. Moderate histamine release. Duration 3 to 4 hours. Fentanyl is 50 to 100 times more potent, with minimal histamine release and a much shorter duration of 30 to 60 minutes. Hydromorphone runs 5 to 7 times more potent than morphine, with low histamine release, similar 3 to 4 hour duration. Oxycodone, given orally, is about 1.5 times morphine's potency, low histamine release lasting 4 to 6 hours. Tramadol comes in weakest, at roughly 0.1 times morphine's potency, minimal histamine release lasting around 6 hours. Notice the pattern. Morphine and hydromorphone both cause more histamine release than the synthetic opioids. That's a natural versus synthetic distinction worth remembering. The neuraxial angle. Here's where morphine's poor lipid solubility actually becomes an advantage instead of a drawback. Give it epidurally at 2 to 5 milligrams, and analgesia can last 12 to 24 hours. Give it intrathecally at a much smaller dose, just 0.1 to 0.5 milligrams, and you can get analgesia lasting up to 24 hours. Because it doesn't rapidly diffuse away from the cerebrospinal fluid into surrounding tissue and fat the way a lipophilic drug would, it stays put near the spinal receptors, providing that extended duration. The trade-off, because it lingers in the CSF, it can migrate rostrally toward the brainstem over several hours, which is exactly why patients who receive neuraxial morphine need respiratory monitoring extending well into the following day, not just the first couple of hours. This delayed respiratory depression is one of the most important safety points in all of neuraxial opioid use. Pulling it all together, morphine, the original opioid, the drug every other opioid gets measured against. Slow to cross into the brain, but that same property makes it exceptional for prolonged neuraxial analgesia. Metabolized into one inactive byproduct and one genuinely potent, long-acting active metabolite that you have to respect in renal failure, and distinctly more likely than the synthetic opioids to trigger histamine release. Watch for the itching, the flushing, the hypotension. Know the pharmacokinetics. Know the metabolites. Watch the breathing. I'm Anesthesia Buddy. Stay sharp. See you in the next one.